the one we always hear about is the nighttime sweats. But from, I guess, my background, my former life, doing continence and uro-gynaecology is to do with urinary incontinence, pelvic for vaginal dryness, lack of libido, that line of things, that fun stuff that comes along with perimenopause and menopause, which is all to do with those hormonal changes as well.
Yes, menopause. It's a topic we don't talk about enough. Nurse Practitioner Shiree Walker is my guest today in part 2 of our Women's Health Special. Last time we covered cosmetic enhancements. It's another area of specialty for Shiree. But this week we're talking crime scenes and pufferfish. Well, they're actually my own descriptions for the unexpected heavy bleeding and weight gain we experience during perimenopause and menopause. Shiree puts the science around this today and outlines some of the surprises we can expect during these years, but also, thankfully, some ideas how we can make it a smoother ride. I'm talking with Shiree Walker again, which is just such a privilege. Hello, Shiree, and welcome back to my warm table.
Thank you. Thanks for having me again.
Shiree, today I want to talk about menopause. It's just something that all of my friends want to know more about, and not just my friends, me too.
Yep.
Want to know more about what this mysterious stage in life actually is from a physical, hormonal, body-changing point of view. And it just seems to be something we don't talk about enough. It's something that people talk about in hushed voices, or when you do hear someone talk about menopause, you can absolutely always hear the sentence, menopause sucks.
Yeah.
So that's pretty much, what we're exposed to. So I'd love you as a nurse practitioner to tell us some of the science and the medical activity that's going on in our bodies at this stage in life.
So I guess from a very basic point of view, if we look at ovulation in women, we are constantly going through this hormonal cycle. So 2 main players in our body in women are estrogen and progesterone, and they will peak and trough at certain levels depending on where you are on your ovulation cycle. So, estrogen kind of begins to rise up before ovulation, and then when we ovulate, that kind of begins to come down, and then our progesterone begins to rise in preparation for implantation of an embryo. And then if that doesn't happen, if we don't fall pregnant, then progesterone will drop, we'll get our period, and we just keep going through this cycle again and again until we go through menopause, or we go on a contraception, or we have surgery to hysterectomy or to stop periods. So I guess at a very basic level, it's evolution. It's what's happening within our bodies until we get to the point where we are no longer going to reproduce. I guess that's survival as well, because as you get to a woman gets older, are they going to be fit enough to then carry a child and live long enough to look after the child to get to adulthood? So it's an evolutionary process as well. That's the easiest way.
Well, it is. It's actually quite basic as that, isn't it?
Yeah.
Exactly.
Yeah.
And I know this colleague that you mentioned, she said to me that there's only 2 species on the planet that actually go through menopause, which I found interesting because once a species ends its fertile life, then they're of no use to the species anymore. So they normally die or get killed off, which is really quite tragic. So, very thankful that that women are allowed to continue on when they're not reproductive anymore, because believe it or not, we're actually quite useful.
Indeed. Yes.
But apparently it's only the human species and I think it was killer whales that are the only 2 species on the planet that go through menopause. I found that staggering. Came home and told my husband. I said, "Did you know?" And his first response to me was, "Oh my God, I'd never want to meet a killer whale during menopause." So, okay, good point. Rude, but good point.
Yeah, and, when I speak to my female clients, even when they're not going through menopause, but maybe just looking at changes in periods and fertility, it is really that hormone, that up that cycle, that's one's going up, one's coming down, one's going up, one's coming down. And, there's a lot of information now about there. You'll see a lot of personal trainers are talking about when they train a woman, how it's different from a man, because our function of our hormones, like I think pre-ovulation, we're at our peak, and that's where we're driven and we're getting everything done. And then after that, I could have lifted like 100 kilos those 2 weeks, but then come post-ovulation, close to my period, game over. So it's this whole process of not just what's happening with our hormones from a period perspective, but just all our well-being. And then getting towards the menopause stage or perimenopause, which can start 10 years prior to stopping off ovulation and then your hormones changing, is that you can get these changes in the body depending on, what's happening with your estrogen and progesterone. So there is a lot of changes as well in the body in regards to stress levels, adrenal issues, just general fatigue in women. So there is this big play between the estrogen and progesterone. We talk about progesterone in women is pretty much being relaxation and chill pill. And you will find in a lot of women who have adrenal issues or fatigue, I say when your body's been in this fight or flight response, when we do testing, their progesterone levels are actually quite low. And then you might give them some progesterone and they just begin to feel amazing, like their anxiety goes, they're sleeping better, they're just feeling chill and relaxed. I actually do have a nursing friend who's in her 50s who actually I've known for many, many years. We did all her hormone testing and she did have some anxiety and got her on some progesterone. Asked her a couple of months after, how are you going? She goes, you know what? I am so chill at work. I am not stressed. If the patient doesn't want to do that, okay, no worries. Right. Yeah.
And that is interesting because I know friends who've never suffered from anxiety, never had anything remotely like anxiety, but leading into menopause, this anxiety has just come out of nowhere. So it's just that perimenopause time is something, again, we don't talk enough about. So I do want to explore some of that. The other thing that women report is this flooding, their period flooding. Now, I call that crime scene because it's like a crime scene. Mm-hmm. And look, I've got my my name for perimenopause is crime scene and pufferfish. Because you out of the blue you're flooding with your bleeding. Totally unexpectedly, and then you'll have nothing for months, and then again you might have a little bit, and then you'll flood again, and it's actually quite debilitating and terrible from a professional point of view because you just never know. And so there are women that I know who are terrified of flooding in the workplace. So it's it is something that again. The reason I want to record this today is to reassure women that you're not alone in this, that we are probably not talking about it enough. And if you've experienced that crime scene experience, then there is someone else who absolutely has been there as well. And then there's the puffer fish. Like, okay, so, all of a sudden my metabolism just decided one night that I'm just not going to play anymore. And I swear to God, I woke up 10 kilos heavier the next morning. Like, it just seemed to come out of the blue. It had nothing to do with the chocolate, Shiree. Don't look at me like that. But no, seriously, that the metabolism just totally just shut down. So there's so many changes that seem to just slap you in the face out of nowhere. And they all come at once. But the good news about sort of progesterone and the chill pill, the anxiety, these things can be managed.
Yes, definitely. So I think the important thing is getting tested and not guesswork. So we know exactly what's happening with your hormones. There's lots of natural supplements out there and different things you could do, or my friend did this, or I Googled this. But I always say, test, don't guess, because it could be counterproductive what you are taking. And, we're in this age where you can order something online from overseas that might not necessarily be approved here in Australia, but you can get it from overseas, but isn't necessarily the best thing for you.
So getting tested so you can actually see where's your estrogen at, where's your progesterone at, where's your testosterone at. So that's the other one.
So there are different tests available. And this is something I've had to learn, coming out of, hospital system where we would do a hormone panel, which very much just did like your estradiol, progesterone. We did like your follicle stimulating hormone, luteinizing hormone, can do your testosterone. But then there are different tests, I guess we call it in integrative or functional medicine, that are available. So there is a saliva test that you can do, which does test your adrenal glands as well as your hormones. Or there is one called the Dutch test, which is the dried urine total comprehensive hormone test, and that one actually gives you a massive breakdown of your estrogen metabolites. The saliva one does as well. That gives us your E1, E2, E3 metabolites of your estrogen, and that will, so it depends on, and they have different cost factors, but that breakdown of your metabolites actually then tells us what's happening with your estrogen pathways as well as your progesterone and testosterone, and then what we need to adjust. So that flooding that you talked of, usually is to do with your estrogen levels, and I guess coming into a state where we might call it estrogen dominant. So there are different health issues for women where we call estrogen dominance, like endometriosis, fibroids might be one as well. And so that can be from a more estrogen dominant state, and there's things that we need to do to maybe look at how your body is actually detoxifying estrogen through the body, and then that might help those pathways and then make periods less of a crime scene.
Less of a crime scene.
But then we can also counterbalance with progesterone, which actually helps to decrease the amount of bleeding, or I don't want to say thin, I guess to a degree kind of thinning the lining of the uterus, but also it helps with that as well. And so it's getting that testing and to know what's happening.
And is that testing, sort of perimenopause is a good time to go and get that testing done?
Yeah, especially if people are symptomatic or from a family history, like, mum went through menopause at this stage. So if people are wanting to know where things are at, but also the testing, I have like young mums or young women who either pre-fertility want to know where things are at, or things haven't been right since having kids and they're not getting any answers. So then we look at testing their hormones and seeing where everything is in the balance or not in the balance.
Or not in the balance. You're more to the point,
Yeah.
exactly. And menopause is defined as it's been 12 months since your last period.
Yeah.
So that's then where they say, okay, menopause is now, you're officially in menopause.
Yeah.
And so what sort of other surprises await the woman in menopause?
So I guess the one we always hear about is the nighttime sweats.
Mm-hmm.
But from, I guess, my background, my former life, doing continence and uro-gynaecology, is to do with urinary incontinence, pelvic for vaginal dryness, lack of libido, that line of things, that fun stuff that comes along with perimenopause and menopause, which is all to do with those hormonal changes as well.
So tell us about, those, can we unpick those? So let's start with vaginal dryness.
Yeah. So that is to do with estrogen levels dropping off, and potentially could be with your progesterone dropping as well. And same, it's to do with cervical mucus, because one way you can track your fertility naturally is if you track your cycle, so you can do like your temperature, but then also your cervical mucus discharge.
I think the Billings method was a big one on that.
Yeah, the Billings method. And so basically and this is the thing as well, it surprises me sometimes women who they think that discharge is not normal, not realising it actually is normal, and it's part of that fertile mucus, if you want to call it that. So as you are about to come to ovulation, that mucus might increase, might get me a bit more like slippery, because obviously the sperm can then pass through that slippery mucus if you're intending pregnancy, and then it marks off. But then if we're getting into menopause and we're not cycling, then that cervical mucus is not happening, which then leads to vaginal dryness. Vaginal dryness then, on penetration can then be quite uncomfortable, can cause bleeding. So it then becomes like a really uncomfortable process, especially if you've been in a relationship, or whether it's male or female, whatever your relationship, and then it becomes uncomfortable. And so then it affects the relationship as well. But there are things that we can do and try and play around with to try and help that process as well.
So what sort of stuff can you do to help counter that?
So I guess simple things though, before we go into medications, is looking at foreplay, use of lubrication. Those are really important things to look at. And I guess changes in conversation with your partner.
I honestly think that menopause is a male issue.
Menopause,
definitely. Let's go the menopause, because my long-suffering husband, he's learning a lot about women's health, or has done so since the very beginning of our marriage. So look, I just don't think we can not talk about it with our partners.
Yeah, definitely. And I think it's a thing, I've had conversations with my husband, he might not want me to say this, but I think as you evolve in your relationship, and I think for women as well, because we're maybe sexually not taught where we're at. Like I went to a Catholic high school. I think we got one session on sex, and the rest was like Dolly magazines.
We got all the Billings method, so I'm pretty.
We got none.
We got
none
the Billings
of that.
method, and we certainly got told to keep our legs closed.
Yeah,
and that's that's pretty much the sex talk.
Yeah, exactly.
And we also were asked to feel our ovaries at one point. So girls, this is
more than us.
Look, we got very, very intense sexual health training in our class, obviously.
Yeah. So I think it's that thing as well, just from a sex perspective, where we have these discussions, and where women, they have that thing where, I guess, that whole cougar, women do come into their sexual prime as they get a little bit older. And maybe enjoy sex more as well. But then it goes on to this, and whether that is a surge of hormones, whether that's getting to know your body a bit better, what you like, what you dislike, or just, bossing up and being like, this is what I want, this is what I need. And then we get to that perimenopause, menopause state where things begin to change. So I think it's that conversation around sex, using, having a lot of foreplay, lubrication, and then it goes potentially down the line of medications for vaginal dryness to make the experience not as unpleasant if you have, friction happening when you're having, penetrative sex. So there are different estrogen formulations available on the market. I'm not going to go into trade names, but they are prescriptive. I know there are probably natural ones on the market, but I'm not going to go into that. But the prescription ones are effectively estrogen creams that are inserted into the vagina or just on the inside. It's not a lot that's used, but normally what it is you take it every night for 2 weeks. So you insert it. And what that is if you kind of think of like, not like a bell curve, but like a graph, you're starting low because your estrogen's depleted. Then it's kind of coming up over the 2 weeks. And then you go to a maintenance dose of twice a week. And then it just kind of maintains. So that's where things. So nurse practitioners, GPs, doctors can prescribe that. There was that little bit of controversy because it's estrogen in regards to breast cancer or family of breast cancer. So it kind of, for some people, they got freaked out and didn't want to go on it, or it fell out of favour. But having gone back and worked in a female hospital just last year, just went back for 3 months, ended up staying for 12, doing uro-gynaecology, that it's kind of come back full circle, and they are kind of going back to that. Or if we're saying, if you are concerned, if you have had breast cancer, to see your oncologist, get the all clear, and then you can move forward with using a cream like that.
Great. So there is help. There are some tricks up the sleeve for vaginal dryness.
Yeah.
So some of the other surprises in menopause, what else are there that we need to be aware of? And let's talk about them.
So could be urinary incontinence.
Yes.
Yep. So urinary incontinence, there are different types. So there is stress incontinence. So that's usually when there's a weakness of the pelvic floor. There's urge incontinence, which is where you get, but by the time you get the sensation in the bladder to go to the toilet, you've got the urge and then you've leaked. Whether that's full bladder is emptied or just a small amount. Then those are probably the main, or you can get a mixed picture where it's stress and urge depending on your anatomy and what's happened in your health history. So those
doesn't make a difference, sorry to interrupt, in regards to your birth story.
Yes. So if we go back to the pelvic floor, so basically the way that I explain to my clients is the pelvic floor is like a sling. It attaches at the front to your pubic bone. It comes all the way back and attaches to your tailbone. Now for women, we have 3 holes that go through your pelvic floor, where men only have 2. Because we have the urethral opening where we empty our bladder from, the vagina and the rectum. So depending on, birth history, traumatic births, use of instrumentations, or maybe, and not necessarily for all women, a birth story, but if they've had complicated gynecology background or surgeries or gynecological cancers, all those type of surgeries can affect your pelvic floor as well. Your bowel habits, straining to have your bowels open, because even though the pelvic floor, that's around your rectum, it can actually, it's like I said, it's that sling effect as well. So it can have different actions depending on birth stories, surgical trauma, a gynecological history, bowel habits as well.
So can a traumatic birth experience actually break the pelvic floor? Like, does it rip, tear, break, sag? What does it do?
I guess essentially,
because I'm picturing a hammock, right?
Yes, swollen and tear, but then it's also that if you don't use it, you lose it, like any muscle in the body. So it's that rehabilitation aspect up until a certain point. There are some people who will then do their pelvic floor, everything goes back to normal. Once you've given birth, all that inflammation and trauma has gone back to baseline, and that that length of time, I can't tell you. That's very variable in different women, because it's also was it a single birth, was it a multiples birth, all this type of stuff. And then doing your pelvic floor exercises, and then you do have specific pelvic floor physios as well that you can go and see, who are very experienced and can rehab a pelvic floor as well, before you would then potentially need to go down the line of surgery or using devices, using vaginal pessaries. So that was something that you can do. So that is if you got, I guess, what we call pelvic organ prolapse, where uteruses and vaginas are just, the vault is beginning to descend down, which can be from vaginal atrophy, which is your drop in estrogen, as well as a bit of your pelvic floor structure not being strong enough. Doing your pelvic floor exercises would definitely be one of those things that can help that side of things.
I just was reading, sorry again to interrupt you there, Shiree, that I was reading somewhere that some schools are encouraging young girls from the age of about 12 to start doing pelvic floor exercises just as part of their routine.
Yeah, and I think about 2 or 3, maybe it was about 2 years ago, one of the endometriosis foundations, they actually got funding for I think it's a physio or nurse to go out to schools to do education about periods, and like about painful periods, what's normal, what's not normal, and part of pelvic floor is part of that education that's going out there. So that's really great as well that they're getting that education at a young age. So,
oh, absolutely. No, that's really good.
And the only thing I didn't mention was, with the urge incontinence. So the best way that I kind of describe to women about urge incontinence is if you think of your urethra. So female urethra is 5 to 7 centimeters. Think of it like a balloon. So you've got a balloon, and then the little bit that you hold that we blow air into.
Yeah.
So if you keep that pinched, that's what happens. When we're not menopausal or perimenopausal, and it stays nice and tight and closed, which means it doesn't leak urine. When you get to perimenopause, menopause, and your estrogen levels drop off, if you unpinch your fingers, it kind of gapes a little, which means air or quote unquote urine can leak out. So that's why urge incontinence might get worse with age in women. So that's when also going on a vaginal estrogen cream can actually help to just bulk that back up. And keep that closed. And so some women will find that they actually get more urinary tract infections perimenopause, menopause, when they've never had really any issues. And that's because that urethral opening is slightly more open than what it has been their entire life. And like I said, female urethra is 5 to 7 centimeters. Male urethra is 15 to 20 centimeters. So it's a lot easier for bacteria, and even if it's just our normal bacteria on our skin, not necessarily like a bad bacteria, but the bacteria to transcend and go up into the bladder and cause an infection, it's a lot easier in women for that to happen.
Definitely, it sounds that way. So we've covered vaginal dryness. We're covering incontinence and pelvic floor.
Yeah.
Other surprises.
I think the one you'll probably find is the night sweats.
Night sweats.
Yeah, which is to do with your estrogen levels dropping and tanking. So, and this is again, I guess, the controversial part, and is whether you go on some type of hormone replacement therapy to just kind of maintain and keep that estrogen in there and getting it at the right balance to counterbalance things like the night sweats. And that's I guess a conversation. Some people are very for it, some are against it, some will look at natural therapies, and this is where, like, going back to testing, but also symptom control. So when we're looking at like hormones, I guess we talk about, if we do prescribe them, starting low and going slow. So we don't just want to, as much as terrible as someone is feeling, you don't want to give them this whole whack of hormones and then, they feel worse. So we would look at starting them on a low amount and then probably repeat testing, whether it be blood test or symptom management. Usually we want to do both, like blood tests and symptoms, in about 8 weeks. And then see whether we need to go up from there or whether we maintain them, or whether we need to add in something else, to just help them symptom-wise.
And there's things now called bioidentical hormones. Like the whole HRT situation has changed significantly from perhaps the time of my mother going through menopause, where HRT was a really bad word. Like you just don't talk about it. You didn't, you just have to persevere and get through menopause without actually taking anything. And when you did take something, there was always these huge risks associated with it. And there's been reports actually debunking some of the studies that were done in those times. Is that right, Shiree? That the fear that was caused about some of the HRT causing breast cancer, was that?
Yeah, and I think potentially that might go back to what we were talking about, the estrogen as well, with the risk of the breast cancer, and even though it's vaginal estrogen versus breast cancer. So just, there definitely have been some articles where it debunks it, but I always tell people, if they're concerned,
check
go back to your oncologist, especially if you do have a history. just get that letter of approval or have that chat, and then you kind of know where things are at, because they are the specialists in that area.
Absolutely.
So there is, I guess, HRT, which is synthetic hormones, and then there's bioidentical. So the other name you might hear is body identical. So they're the closest type of hormone to our bodies, and that is another way that's going to help relieve symptoms. It's one of those areas, it depends on who you speak with from a health professional perspective as to whether they're for or against it. So this is where I think patients can get a bit stuck, because they're getting pulled, or it's, I guess I kind of call it like the girlfriend effect. It's because my friend had this, now I want to look after it, or they've never heard of it because it's because someone's told them rather than it's out there.
Okay, so there's been huge advances in that area. So, and there are practitioners who can actually work with us to alleviate any of the fears or concerns, and actually work through what is actually going to be right for our own experiences of menopause, and also what we want to achieve through menopause. Because it could be that you're actually okay with the night sweats, but it's the anxiety that you just don't want to deal with, or it's the it's the dryness or the incontinence. Like there's so many things you could sort out,
and there's potential things like with the heaviness of the periods. So the one thing that you can do is potentially with progesterone, you can go on it all cycle. So you, like I was saying before, your progesterone kind of peaks after ovulation in the process of getting ready for implantation of an embryo. If I have a client who's like, Shiree, I just want my periods to stop, you can actually trial putting them on progesterone their entire period, their entire cycle, because your body is thinking to a degree that you're pregnant. So then you don't shed the lining of your uterus and it stops your period.
Is that what the Mirena does, or some of those other artificial contraceptions?
Yeah, the Mirena has like a so you've got like I guess the copper IUD doesn't have hormones. It's just this little maze that sperm aren't meant to be able to.
It's like a little wiggle.
Get through. Yeah. And then Mirena.
It's too confusing for the boys.
Yeah. Exactly. And then your Mirena will have different hormones in there, but for some women they can still get through breakthrough bleeding with the Mirena, so it doesn't completely eradicate that bleeding. I get some women who have no issues, and others who are like, I still know when I'm ovulating, I'm bleeding, or I've like bled the entire time I've had it in, or it just makes me feel like crap. And I'm not to say that it's not to be used. For some people, it has great effects. In some women with adenomyosis, which is like a sister disease to endometriosis, the definitive surgery for that is a hysterectomy, which someone might not be wanting to go down that line, but they do talk about putting in a Mirena might be a good way to go to just help with that symptomatic control of the heavy periods and the clotting and bleeding that comes with that. So
it's just rich with issues, isn't it? The whole female body is quite a miracle.
Yes.
It's quite the miracle, and it creates beautiful miracles too. So it's an extraordinary machine, the female body.
Yeah.
How long does menopause normally last?
That's another kind of variable, depending on.
Depends
on, yeah. So I guess if you take into effect the perimenopause to menopause state, I guess it could be like 10 to 15 years, depending on symptom wise. Some women get away with it. I speak to them and they kind of go, no issues, just sail through it. And others were like, just dragged on and on and on. So it is always that variable, but that's why I think getting that symptom control and seeking out health sooner rather than later, can kind of bridge that gap for you and make the experience not as unpleasant.
Well, that's right. And look, with modern medicine and with compassionate and caring practitioners around us as well, there are so many tricks up their sleeve to actually, help manage the symptoms and the situation as it is, and to also suit the busy lives of women in their 50s or 40s and 50s, because, we are living in a modern society where we do lots and lots of things at the same time and need some sort of understanding of how we can manage our menopause during that.
Definitely. And I didn't really touch on natural supplements as well, because there are other things that can be used out there to help counterbalance part of the perimenopause menopause state as well. So it's not necessarily always medications, but there are other things like natural supplements that people can use as well to help relieve some of those symptoms as well, depending on which way someone wants to go. So you have a lot of people who push back with the hormones, and if that's not their jam, that's fine. we can potentially work on these other supplements which might help depending on what's happening with your estrogen and progesterone. And it might help them, might get them to a point where they feel okay, and then in time they might want to progress to hormones, or they might just be like, I just want natural, and this is where they stay. So it is that balance as well as of what a client wants.
Is there any dietary changes that women need to make in that time as well?
I guess for me, because I guess it is that thing about the weight gain seems to be the issue. So I always kind of think about, and listen, I do not have a nutrition background, so I'm going to just,
declare that.
And I'll be honest, I don't know enough about these to say this is a definitive, but I do know some clients have gone into keto, have had good results. I think this is where we need to potentially look at other testing as well, because diet I think is definitely 80% of where we go with weight loss. I always think going like gluten-free, dairy-free, sugar-free, if we are getting the weight issues, is probably the way to go. But this is where I think checking other tests in the body, like checking your thyroid function, checking your blood sugar and insulin level for insulin resistance, because those are things that can definitely affect weight gain if that's a concern for women during menopause or the perimenopause state. And that's things that kind of get shoved under the table or forgotten, unless, especially for thyroids, unless you have some type of definitive thyroid symptoms or family history, there's certain thyroid testing that's not necessarily always done. And same with the insulin resistance. Certain practitioners are like, I don't bother to do the insulin. And then, we might do insulin resistance and find it's sky high. So they actually might be pre-diabetic. And, insulin resistance is very much where they hold that weight around their tummy. So sometimes you can actually just have a conversation and be like, where on the body is the weight gain? They go, it's all on my tummy. And then go, right, you get these flags, right, this is our next step of testing that we need to look at. So and then that, if they're pre-diabetic, then we go into there's lots of different ones around, but probably like your low sugar, low carb type of diets. Once again, not a nutritionist, not a dietitian, not a diabetes educator, but you can delve a lot further into that, but you can just start the basics and beginnings of that based on what those results come back with.
Look, there's just so many forensics you can do at that point, aren't there? Yeah. And it really is that case of every woman is different, every body's different, every menopause is going to be different, but there certainly are some gateways there of what you can start having a discussion about. So it's finding, I guess, for some of the women listening, finding a practitioner that you're happy to have those conversations with as a starting point, and then starting to uncover what the diagnostics are telling us and finding the way forward from there.
Yeah, and I also think for women, there are a lot of GPs, nurse practitioners that are quite open to having discussions. So I always think, I do tell people to keep like a period tracker or a diary and symptoms, because then you are the best one by far to know exactly what's happening with your body and what the timeline is. And then you can go to your practitioner going, this is what's been happening. And period trackers are great because they can chart everything out for you and tell you, if you have random spotting, was your bleeding heavy, were you flooding pads, symptom wise. So they give you some really great data to be like, this is what's happening with me, and we need to now action and work on this.
Shiree, thank you again. You're a font of information, so much that is relevant to us today as women just trying to get through the day. Really appreciate your time again today talking with us on My Warm Table.
No worries. Thank you. Thanks, Sonia.
You've been listening to My Warm Table with Sonia Nolan. In Italian, a tavola calda is a warm and welcoming table where you can share big ideas, friendship, laughter and life. So much happens around the kitchen table, and I wanted to amplify it here in this podcast. My aim is to feed your mind and soul through smart conversations with heart. No topic is off limits, but good table manners rule. I hope you'll join us each week as we set the table for my extraordinary guests who will let you feast on their deep knowledge, life experiences and wise insights. Let's keep the conversation flowing. Please subscribe to the My Warm Table podcast and share it with your friends and networks. Perhaps if they are new to podcasting, take a moment to show them how to download and subscribe so they don't miss an episode either. I'd also love you to join our community on Facebook. You'll find the group at My Warm Table Podcast. Your support is very much appreciated.